Hello, everyone, and welcome to today's webinar, Current COVID-19 Testing Landscape, the Role of Antigen Testing in a Molecular World. I'm Susie Valdez of LabRoots, and I will be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by DiaSorin. To learn more, visit them at diasorin.com. Now, we encourage you to participate today by submitting as many questions as you want during the presentation. To do so, simply type them into the Ask a Question box and click Send. We'll answer as many questions as we have time for at the end of the presentation. You may also submit any technical issues here as well if you have any trouble seeing or hearing this presentation. Also, this presentation is educational and offers continuing education credits. Please follow the process to obtain those credits by clicking on the Continuing Education Credits window. I'd now like to welcome our speaker, Dr. Tran, Professor of Pathology and Laboratory Medicine at UC Davis Health. Dr. Tran, welcome. You may now begin your presentation, sir.
Great. Hello, everyone. Definitely a big thanks to LabRoots and so on for allowing me to present today. And as noted, today we're going to talk about the current COVID-19 testing landscape and really the role of antigen testing in a molecular world. I'm Tran, so my background is I'm a clinical chemist, board certified clinical chemist, but I also have extensive background in molecular infectious disease testing and played a role in deployment of several molecular tests for COVID-19 during this pandemic at our institution. I also serve on the California COVID-19 testing task force as well. Some quick disclosures: I am a consultant for Roche Diagnostics and Roche Molecular Systems, and our institution, specifically the molecular lab, is a Roche Diagnostics Molecular Center of Excellence. And that's a picture of our institution up there in Northern California. For those that don't know where UC Davis is located, we're specifically located in the city of Sacramento, and that's our health system, whereas the college itself is located in the city of Davis, hence the name. All right. So some quick learning objectives. Our goal here is to really talk about the practices of antigen testing, and you see big red words down there that the slide is current as of March 1st, and this indicates how fast the science is moving right now. And as we've done since March 2020, data comes out new each morning, each day as we look through the internet, and of course guidelines may change in the same manner. So we're going to talk about CDC guidelines, we're going to talk about best practices, we're going to talk about how point-of-care testing versus high-throughput COVID-2 antigen testing can compare against molecular approaches, and then discuss considerations for using SARS-CoV-2 antigen testing in asymptomatic versus symptomatic populations in resource-limited settings. And these are kind of the key areas that we'll focus on today. So keeping up with this epidemiological data is quite challenging because the number gets bigger and bigger each morning I wake up. But for the most part, and this is data from January, you can see that we have over 100 million cases in the world. And as you know, COVID-19 stemmed from Asia as we understand it, and of course spread across the world. And of course, the United States leads in terms of the number of cases, which highlights considerations on what type of testing practices we should follow as numbers continue to rise across our states and various other regions in North America. And of course, here's a picture of statistics as of January 27th, how the United States fared during the COVID-19 pandemic. And you can see that some states fared better than others. Some states, if you look back in time, had more cases per their population than others, but now are doing better. And all these vary because of population density, various practices of social distancing and masking, as well as other measures being put into place, including testing capacity and so on. But for the most part, you can see that we have over 25 million total cases. The number continues to grow, and the number of deaths do or have reached a level where, you know, it's past 500,000 already as we've looked into this data. So what did UC Davis do during this entire ordeal? And UC Davis does have the distinction, not that we're necessarily proud of it, but the distinction that we were the first place in the United States to encounter the first known community-acquired case of COVID-19. So that was February 26th. And what that inspired us to do was we needed to move much faster, mainly because the virus was literally at our doorstep. And you can see here the timeline going from February 2020 out towards the future. We really traced traced our development of various COVID tests relative to what FDA allowed us to do. You can see February 29th was our so-called D-Day, where the FDA did relax regulations, allowing commercial and regular clinical labs like ourselves to actually deploy and submit data for an emergency use authorization for COVID-19 tests. And shortly thereafter, commercially available COVID tests based on the CDC assay was also available, but of course, we're in very short supply. In fact, by March 19th, we were one of the few places in the state that had the capacity to run testing, and everyone was really competing for the same instruments, the same RNA extraction kits, the same pipette tips, perhaps the same PCR plates, and so on. And that started a very long saga of short supplies and so forth. At our institution, we were also very lucky to have had already installed a few months earlier, so December of 2019, a high-throughput PCR system. So this is one of the automated platforms, which when an assay became emergency use authorized on it, we were able to deploy it just 9 days later. So on March 28th, we deployed the first high-throughput PCR system in the region, and our sister University of California hospitals, which had similar platforms, did the same. We continue to add more testing, just as many of you in the audience who dealt with COVID-19, you were adding more tests, more capabilities, expanding, and really our doctrine starting in late February was first to deploy testing as soon as possible, followed by scaling to meet the needs of our patients first, and then see what else we can do thereafter. And then lastly, but certainly not least, begin incorporating other PCR tests that can help augment testing in special populations, such as the emergency room, perhaps the community, perhaps special populations such as our transplant patients needing to get cleared for a kidney. You can see by April, we brought in serology testing. We brought in backup instruments because we knew that all of our eggs are now in one basket with that one high throughput system, so we got a second one. We also looked at PCR platforms, as noted, with our third component of our plan was to bring in faster tests. So in this case, a platform was deployed by April 30th that was able to get results back in about an hour and a half. And that continued throughout the entire year, and we'll go into details of what other platforms we used. At the University of California, and specifically UC Health, so these are 5 hospitals under the University of California, so UC Davis being one of them, but you have University of California, Irvine, Los Angeles, San Diego, and San Francisco. And you can see that we were pretty much strategically located across the state of California and centered around population dense areas such as Los Angeles, San Francisco, and so forth. And Davis, of course, helped into areas of the Central Valley. And you can see all 5 health systems rose up to the challenge and began increasing our testing capacity to support the growing demand of the pandemic. As we deployed various tests, we became very much appreciative of what this virus was and what we were trying to target to get results to our healthcare providers so that they can make the best judgments. SARS-CoV-2 is an envelope positive sense single-strand RNA virus. It's related to MERS, so Middle Eastern Respiratory Syndrome, as well as severe acute respiratory syndrome, SARS virus, as we used to call it, or SARS 2003, and now, of course, we call it SARS-CoV-1. The mechanism for infection is binding via the spike protein, which are these mushroom-shaped proteins shown on the left right there on that viral cartoon cross-section. And these bind to the ACE2 receptor found in various organs and tissues that we have, which then facilitate the virus to invade those cells and, of course, take advantage of our host machinery to replicate. Detection is primarily and is accepted to be molecular diagnostics. And molecular, of course, typically means polymerase chain reaction, or PCR. This being an RNA virus, we have to add 2 words in front of PCR, and that's reverse transcriptase or reverse transcription PCR. So we got to convert the RNA to DNA before we perform the actual PCR steps themselves. There are other techniques that are non-PCR based. These include isothermal methods, which I'll mention very briefly. But for the most part, when we hear molecular approaches, the majority of tests out there today remain RT-PCR, so reverse transcription PCR for COVID in this case. At the end of the day, PCR molecular approaches really serves to amplify a small signal, which is the strand or strands of RNA of the virus, amplify it many times so that we can actually measure it accurately and so forth. So when we talk about these molecular tests, we talk about targeting genes. So we use these genes as a surrogate for identifying the virus itself. So you can see here, these are the common tests we use at UC Davis. These are 4 tests specifically. And you can see that each of these tests do target different genes, which work quite well for us because it gives us options in the event that there are perhaps mutations, variants, and perhaps situations where the viral load has gone down because it's recognized that the genes that these viruses replicate may not always be replicated in a one-to-one fashion. Some genes may exist more than others. These subgenomic RNA can help us improve detection of the organisms at certain stages of infection. We unfortunately don't have time to talk about the science behind that, but the take-home here is not all tests are created the same. The genes do matter, and sometimes they don't compare well just because for that reason, in addition to other pre-analytic factors that we may have to factor in. We're very lucky here that these platforms targeting these genes avoid the regions that have become identified in variants. So you can see that the UK variant, for example, there are mutations in the spike protein. Therefore, it means that this S gene, in this case, could have changes. Likewise, the open reading frame or ORF8 region may also have mutations that can affect the performance of some tests. Does that mean that these tests, you have a test that detects the S or ORF8 region, it's a bad test? No. Many of the tests that have been employed today target more than one gene, and oftentimes you're able to at least pick one of the 2 or 3 genes that are designed to be detected in these assays. So, you know, it just makes you have to keep your eye open as these variants do emerge and so forth, because we are seeing these variants take over very quickly. In fact, I think recent news reports say that the UK variant is now the predominant strain in the United States. Here's a table illustrating, and for educational purposes only, 5 tests that we deployed at UC Davis. And you can see that we kept adding new tests. And you can see here that we have how fast they are, how low they can detect in terms of the RNA, how sensitive they are, how specific they are, the test capacity or their throughput. I do want to mention that sensitivity and specificity are indicated on here really more so to allow discussion and understanding by all populations. So I do recognize that there is no gold standard for COVID testing, including molecular diagnostics. So from the FDA standpoint, we should be calling sensitivity positive % agreement and specificity negative % agreement. But I do know that outside the United States, that terminology may not be used. But you can appreciate from this table that as we looked at the various tests, including the first test we deployed, they do have different flavors and capabilities to detect the organism. You can see that as we evolved, we got more and more sensitive tests, and the limit of detection, or LOD, as indicated here, our best test right now can detect as low as 1,800 viral RNA copies per ml. These values right here may differ from what's reported by the manufacturer in their product insert. This is data from the FDA's reference panel, so this gives us means to compare apples to apples, hopefully. But you can see that some of these tests are slower, but they can churn out more results at once. So our second row right there, that high throughput system, can do 94 tests every 3 hours. But we also have very fast tests. You can see November 3rd, we deployed a very rapid 20-minute PCR test that actually also detects flu A and flu B in addition to SARS-CoV-2, but you're limited to testing one sample at a time. This was highlighted by our press release here. We were one of the first places in the country to deploy this test, and we have a nice multi-center paper out there with a variety of collaborators that show the real-world performance of this test. And the best part is it is indeed 20 minutes, and it can be used by waived users. And we, in fact, deployed it in our emergency department and select clinics, and we've expanded it further since then, allowing populations that need rapid results, where rapid decision-making is required, allowing folks to use this test very easily and to be able to use it and get results on time and take action as needed. What's fascinating during this pandemic is now we see the emergence of home molecular testing, and some are prescription based, so it needs a prescription, others may not. We're heading in that direction. And I can say that from a laboratory medicine professional, I definitely saw the potential for point of care infectious disease testing using molecular techniques. That definitely was in the tea leaves, but I definitely did not see how fast we got to the point where we now have a home molecular test. This platform here, I believe it was the first to be approved on November 18th, 2020. And in this case, it uses an isothermal molecular method. It is, quote, less accurate than PCR, but, it is still very good. It is still a molecular test. We're just comparing, this to the effective accepted standard being PCR. It is pricey, about $50 per test, but as these technologies scale and grow, you can see these numbers change as they move forward. It seems to have a agreement of about 94% with PCR. So again, take that for a bit of a grain of salt, because these results comparisons, they are against different methods, so there is still no gold standard, but that is a very promising 94%, and this opening of home testing does create new opportunities to address this pandemic. In particular, how do we screen populations, right? So for those that were in the thick of things with COVID-19, early on, really your colleagues at the bedside, your patients, perhaps even the community, everyone just wanted a way to test for COVID. But as the pandemic evolved, probably by the time we got to April, the question comes up, should we be testing everyone? Because we became more appreciative of the fact that these asymptomatic populations were spreading the virus without anyone knowing. And the question came up, should we be testing everyone with PCR? Should we test them every day, every other day, every week? Those questions were very important. And the question about testing frequency is important because of the fact that if you just test someone every 3 days or every week, you may miss that window when they have high viral load, which would make them perhaps more transmissible, more infectious, as it were. And you can see here that may be cost effective and resource effective. However, you now gave folks 3 to 4 days of walking around and interacting with the rest of society while they are at peak viral loads, right? And that may not be as helpful, especially when we were at the height of the pandemic. On the flip side, if you're going to test everyone every day, once a day, every day, so that you can catch that moment when their viral load is detectable, that sounds great. It may not be great from a nasal swab or nasal pharyngeal swab standpoint, but more importantly, it would be very expensive, supply chain constrained, and so forth. So it comes back to what's on this website, rapidtest.org, and it highlights work and suggestions by Dr. Michael Minna that identifies that testing frequency and test availability is perhaps more important than sensitivity in the context of trying to control this pandemic. And I know early papers even suggested a sensitivity as low as 70% could still make a difference. And the logic behind this is, yes, if 7 out of 10 times you're going to be able to get that right, but of course 3 out of 10 times you're going to have a false negative, but you're able to repeat testing the next day where both you're rolling the dice again, the metaphorical dice again, but also at the same time you're allowing the viral load to creep up a little bit more in the person so that you can pick them up. This may play a big role. For those that have been trained in lab medicine, you typically were taught that no test is better than an inaccurate test. And whenever anyone hears these stories of, well, 70% sensitivity is good enough, you hear a gasp. You should have no test is better than an inaccurate test. But the question now a year later from the pandemic, I ask, what do we really define as an inaccurate test today and for this purpose? Are we here to diagnose someone to know if they need to be treated, if they need to be admitted? Yeah, we definitely need a good test. But we're just screening populations to be able to pick up infectious people to minimize clusters of virus. Perhaps a lower sensitivity may be useful, but it requires everyone to be playing the same game. And therefore, you see that blue dot right there on the left. You can see a rapid test that detects the virus at that point may be useful. You lose a little bit of sensitivity, but if it's available, it's cheap, and so forth. And as highlighted here, this model of testing is only achievable with rapid, readily available, and cost-effective testing. This brings us to the other arm of testing. So we have molecular approaches initially, and now we discuss immunoassay approaches. And the early immunoassays really revolved around serology testing, which we won't spend any time on this topic today because that's not the point of this presentation. But just briefly, obviously serology testing is using immunoassays to detect our antibody response following exposure to SARS-CoV-2, and perhaps one day we may be able to also identify if you are immune or not. That's still up in the air, and we're still waiting on the science to evolve and, of course, guidelines to evolve with it. In the context of of diagnostic testing, immunoassays can be used to target viral structures. So going back to that cross-section of the virus that we have right there on the left, you can see assays could perhaps target the spike protein and perhaps target the actual nucleocapsid proteins, which is the most common. The data we pulled back in September, there were quite a few tests out there, and the vast majority of them were aimed at targeting people who were symptomatic, right? These are the people that perhaps have the highest viral loads. These are the people that have the highest pre-test probability to have a true positive result. It is recommended in a lot of these assays that populations that have a negative result should be considered presumptive and may require retesting with a molecular method. And often the results that we see for these tests on their information for use, so their product inserts, show a sensitivity of about 84 to 96%, and hopefully better tests are to come. The tests that we see often early on were point of care tests. So some required a reader, an instrument, others did not. Most are lateral flow based. In fact, this picture here, these are all lateral flow based or similar lateral flow based tests out there. Some even had a smartphone app that give you a so-called pass that shows your test and how long ago you tested. And they're very cheap to produce and easier to manufacture compared to molecular diagnostics, even if compared to home molecular tests, right? So if you use the analogy of a urine pregnancy test that's available over the counter, that's how easy it is to make these tests. So going back to the model that Dr. Michael Minna suggested here, we really have some choices as we went through the pandemic. We could go down the pathway of high frequency PCR testing. That's expensive, resource intensive. And oftentimes many facilities found out that they're going to have to come up with their own custom tests to bypass common supply chains and so forth. Some have even used sequencing-based technologies to get the numbers up. But you pay a price. You pay a price oftentimes in terms of how long it takes for you to get a result when you test en masse. So for example, and I'll just propose this to the audience today, that's great that you can do 100,000 tests per day, but how fast can you accumulate 100,000 samples to be able to run it, right? It's not going to take 20 minutes. Right, so still will take a bit of time, and oftentimes that we've seen, best case scenario, most of these places are turning out results within 24 hours. That's fantastic, but oftentimes we're talking a couple days, so 48 to 72 hours. And of course, as you saw during the height of the pandemic, various commercial labs actually even have turnaround times that were even on the order of a week and a half, which was unfortunate. So this goes off to the next model of, well, if we can't churn that out, handle that many results every day because it was expensive, we can test people every 3 days. And that makes sense because you can accumulate enough, you have some time to run it and get results back to people, but that's still, there's windows of time where people can still be infectious and you may not know until it's too late. So if you tested on Monday and retested the person again on Friday and they were negative Monday and positive on Friday, when did they become positive and how many people were they exposed to between Monday and Friday? So those are the challenges that we face with these types of tests. When antigen testing came out, we were very happy from the perspective that acknowledging that they may be less sensitive than PCR. We were excited by the fact that we now have another supply chain, another option, and perhaps means to test Dr. Minna's hypothesis, in this case, to test frequently with a cost-effective, perhaps readily available test. Unfortunately, a lot of these tests were not fully available. In fact, the Department of Health and Human Services actually sequestered a lot of these tests. So early on, these weren't available, and they were targeted towards communities and some health systems, and also retirement homes and nursing facilities, skilled nursing facilities. So we also recognize as we tested populations, and perhaps these weren't the best populations, these could have been low-risk populations, they were prone to false positives. So even if these tests had a 99 or 98% specificity, when the prevalence was low, your positive predictive value isn't so great, right? So we can do the math there and see why that is a problem. But we do see that later point-of-care antigen tests, this is from our colleagues at UC San Francisco, they show here that these tests were able to do reasonably well, and when we actually evaluated their sensitivity relative to what's called a CT cutoff, so if you recall from PCR testing, real-time PCR reports CT values, which are cycle threshold values, and the bigger the CT value, the the lower the viral load is right there. So if you're able to kind of put antigen testing and PCR testing on so-called more even ground to compare, we may have to define a CT cutoff so that we would know when perhaps a person is likely to be antigen negative relative to PCR because they are perhaps convalescing and there's less viral load, where there's no more proteins that are present. The virus isn't producing as much proteins, replicating as well, and therefore that's why the antigen is lower. If you look at data from the Cochrane report, there's actually quite a recent review here, and this is from March 24th. They looked at quite a few studies. So in this case, for symptomatic patients being tested by antigen testing, you see from 37 evaluations consisting of 27 different studies and summing about over 15,000 samples, you can see that the overall sensitivity of these tests are about 72%. Specificity is reasonably good at 99.5%. But the other thing I want to call your attention to is asymptomatic testing. And this is where the focus has been now, because we're talking about reopening schools, businesses, reopening whole states, whole cities. And the asymptomatic population is where we worry. And unfortunately, you can see here that the sensitivity is at about 58%. Specificity remains reasonably good, so at 98.9%, but sensitivity did suffer in this cohort. If you look at the types of tests that were looked at, you can again see the symptomatic versus asymptomatic patients. You can see the sensitivity and specificity do vary by different platforms too. And you can see in this case, amongst the asymptomatic population, one antigen test appears to have, at best, a 69.2% sensitivity when compared against PCR. So what does all this data tell us, and where do we need to go from here? And this data tells us that we do need better antigen tests. The point-of-care tests have a role. I'm not trying to discount that they may not perform well. They have a role. We need to test in the right populations. But we now are coming to an age of laboratory-based antigen tests. And how does this change our understanding and appreciation for deploying these tests? In contrast to point-of-care antigen tests, as I've shown you, which can only really do one test at a time, laboratory-based antigen tests are going to be high throughput. They're going to have scalable reagent supply. They are going to perhaps be lower cost due to economies of scale. Why do I believe that? Well, for those that operate in a clinical laboratory, specifically in clinical chemistry, you know how many thyroid hormones you run. You know how many vitamin Ds you run. You know how many cardiac troponins you run. And manufacturers can scale to that reagent level. And so just for context, we could be looking at tens of thousands of tests per day. They are definitely cheap. In some cases, we could have only a few dollars per test. So you can see here that there could be some potential improvement in sensitivity because we're using perhaps laboratory-based analyzers, so that may be of value compared to point-of-care tests. But what's also valuable with these laboratory-based tests is they don't use proprietary media. So what I failed to mention earlier was these point-of-care antigen tests, very convenient, very fast, but they often use a proprietary media that required you to pretty much add some reagents, which pretty much make them not feasible to be rerun by PCR again. In contrast, some molecular platforms may be able to use residual sample from laboratory-based antigen tests, and these are things that are very exciting as we move to the next phase of testing during the pandemic. So the pros and cons here really for high-throughput lab-based antigen testing for COVID-19, you could be looking at 3,000 tests per day on an instrument if you have the right instrument. The claimed sensitivity specificity has been reported to be about 97% sensitivity, greater than 99% specificity. Reagent supply seems to be stable. Sufficient volumes, the capacity could make a noticeable dent in testing deficiencies in hospitals. The sensitivity is acceptable for these populations and could be used for low-risk patients. The cons, however, a lot of these tests require you to add some sort of reagent, a lysis buffer or stabilizing buffer. Sometimes it's within a very short period of time, so within 12 hours of collections. Others we are seeing at 24 hours of collection. You can have staffing limitations. Who's going to be the one that aliquots these pipettes in these reagents to stabilize the samples, right? So you may have to think about that if you lack automation or automation that can do that. There is a shortage of sterile pipette tips at the time of putting together this slide. It's still not that great, and you should be using sterile tips. And this would affect, if you don't use sterile tips, you can't reflex the PCR, right? You could be introducing contaminants. Reagent stability, that's going to be ever evolving. As manufacturers roll out new tests, you see that they will have shorter stability. And of course, as time evolves, you'll hope that they will have a longer stability time. So at UC Davis Health, we were very lucky to have access to a previously laboratory-based antigen test, which now has received emergency use authorization. And in full disclosure, we brought this test in, evaluated it, mainly because we were very concerned in December and January that our PCR supplies were dropping too quickly due to that last surge. So this laboratory antigen test was going to be our backup plan. Fortunately or unfortunately, we never deployed it. So we were able to have some good data to see how well it worked compared to our PCR platform. But you can see here that we looked at all symptomatic and asymptomatic patients and compared them all combined too. But we also applied that CT value cutoff, and we looked at comparing without a CT value cutoff. We looked at comparing with a CT value of 33. We looked at comparing against a CT value of 30 on PCR. And you can remember, just higher CT values mean lower viral load. And what's important to appreciate here is that on the bottom right-hand corner, we are ultimately having a 95% sensitivity and 90% specificity in this case. So ultimately, this is reasonably good, and this only occurs when you have a CT value of 30. So this is an important point to appreciate. And you look at CT value of 33, it's not too bad either, a sensitivity of 92.7% for symptomatic patients, and asymptomatic has 78%. This isn't too bad, and it actually allows us to evaluate the actual process for actual using in these populations to screen for patient populations. So with that said, we ultimately appreciate here that these tests could be employed if we can come to terms with using CT cutoffs as a means to put PCR on the same plane as antigen testing. This leads us also to the discussion that can a person who's antigen negative but PCR positive with a high CT value be actually infectious or not, or perhaps less infectious? No one has an answer to that question yet, but you can perhaps feel that is a provocative hypothesis because of the fact that if the viral proteins aren't there, are the whole viruses there at all? We don't know that. And there are challenges in how we can test for that with viral culture and so forth, because there are limits to that technology as well. Regardless, as we look at how CDC guides us in this case, they went with a prevalence and pretest probability-based algorithm. So you can see here, if you are symptomatic and you are antigen positive, they're going to say that you are infected with COVID-2. So they're not going to require you to confirm that antigen result. However, if you're symptomatic and antigen negative, you may need to actually follow up with some sort of nucleic acid amplification test. Next, in the middle column, you can see if you're asymptomatic and have close contact with COVID-19, chances are if you had someone that was near you with COVID-19, you're more likely to actually catch it, right? So therefore, if you're antigen negative, you're likely to be truly negative. If you're positive, then they would recommend that you confirm by NAAT. Lastly, and on the rightmost column, you can see that asymptomatic patients with no known exposure. Obviously, if you're antigen positive, let's see if that's a false positive or not. So they're going to need you to reconfirm. If you're antigen negative, then it's likely that you are not infected with COVID-19 or SARS-CoV-2. So in conclusion, the COVID-19 pandemic has created unique challenges globally with laboratory medicine playing a central role. Diagnostic testing consists of molecular and antigen testing. Antigen testing is slowly emerging as a potential low-cost adjunct to molecular solutions. Early SARS-CoV-2 antigen tests exhibit low sensitivity and specificity. Things are improving, such as these newer laboratory-based tests that we are seeing, especially as we assess them in more even grounds with looking at their CT values when they're compared against PCR. Our best practices right now is SARS-CoV-2 antigen testing should rely on pretest probability as defined by CDC guidelines, but the technology and the science continues to evolve and so forth, so we'll have to wait and see. But we do see a valuable role of antigen testing. You just have to use it in the right population. So with that said, I'll close out, and I thank you everyone for your time, and I'm now happy to answer any questions.
And thank you so much, Dr. Tran, for that informative presentation. We will now start the live Q&A portion of the webinar. If you have any questions you'd like to ask, please do so now. Just click on that Ask a Question box located on the far left of your screen, and we'll answer as many questions as we have time for. So let's take a look. It looks like we already have a few questions that have come in. So Dr. Tran, is PCR testing screening for DX-CoV-2, etc., the only real option given its recognition to the gold standard?
And I think that's a great question. So I would probably say there's a couple answers to that. It really depends on what you want to do with that result, right? So for instance, if we definitely need to act on a result, meaning that we're going to give you a therapeutic, a life-saving therapy. We're trying to figure out why you are super sick and needing to be admitted. Yeah, molecular testing should be the primary means to do that. If you are talking about needing to get tested to go fly on a trip, there's a lot of discussion with that. So various organizations, the airline industry, and so forth in different countries have a lot of opinions on this. Right now, they're saying it's going to be molecular testing of some kind. I don't believe as of yet antigen testing is accepted as a pre-test and pre-return screening tool for testing. Other perspectives, however, if you're really just looking at seeing how your risk for having COVID-19 based on what I showed you on those CDC guidelines, antigen testing may work. A good example of this is our use of antigen point-of-care testing as part of migrant worker testing at UC Davis. So these are people that don't have the financial means, the travel means, or really the time to come to a hospital to get tested with our fancy molecular tests. However, there's a lot of these people out there in what are called diagnostic or testing deserts, as it were, and these are high-risk communities. So we decided to deploy antigen testing out there because there's no real cost-effective solution for molecular point-of-care testing for these populations. So in this case, we use antigen for that, and that does play a role.
Thank you so much. Now, what do you see as the biggest challenge with antigen testing for COVID-2?
I think that the two challenges are, first off, whatever we decide to do, we have to go all in. We can't have a situation where some people decide to use antigen, some don't. And for any pandemic-related solutions, everyone has to be rowing in the same direction, to use that analogy. Otherwise, it's going to be piecemeal, and unfortunately, a lot of the early pandemic response was that. And that's because of sheer desperation, right? People were looking for different types of tests. Now, the second issue, and I feel this is the bigger barrier, is really healthcare, health sciences. We've all been programmed, including me, we were all programmed that molecular testing is the way to go. And in some cases, it's extremely hard to break healthcare practitioners away from what they've been trained. And I understand it because that the potential for a 10 to 15% false negative rate does scare people. However, like I said many times in this presentation, it's who you're testing. Because if you talk to a population where there's hundreds of thousands of people in a testing desert where 0 people or very few people have access to testing, that 85% sensitivity or even 70% sensitivity starts looking darn good because that means that I'm catching a majority of people that would have the disease to prevent spread to others. So I think the challenges with antigen testing is we are victims of having been ingrained in the PCR world, the molecular world, but also at the same time, it's going to be hard for people to get away from the news stories where early antigen tests were used probably in the wrong populations and causing false positive and false negative results, and it has incurred a perhaps less than ideal name, and that can be a barrier to adoption at various facilities.
Thank you so much. And we have one more question from our audience. Where do you see in lab high throughput antigen testing fitting in as we move forward in the pandemic?
I think as prevalence goes down, that will help a lot. And I think as people start realizing how much it costs right now, because early on some tests were subsidized, some tests were augmented by various means. But when it's still double digits or plus or triple digits for PCR tests, it starts adding up. And And I think as the prevalence goes down, we have a handle on the virus and the majority of people are vaccinated, antigen test starts looking real good because of the fact that they are going to be inherently cheaper. They are fast. The data for it looks good as long as you use it in the right population. And I think that's where it's going to be. Let's put it into context. HIV testing, and I know, this is not COVID, but for context, and perhaps I'm comparing apples and oranges, because obviously HIV doesn't have a 30% asymptomatic population to worry about. It's not spread by airborne droplets. But at the same time, you look at the primary means to screen for HIV is actually antibodies and antigen. The molecular test is expensive. We only do it to effectively confirm and look at viral load. So all these things are things to consider as we shift to the post-pandemic world. How do we be able to cost effectively administer testing for large populations as part of routine care? PCR is not going to go away. It'll be used for confirmation and perhaps still testing in high-risk patients. But antigen, I feel, has a role, especially the lab-based platforms, because they have just so much capacity and can do so cost-effectively.
Dr. Tran, thank you so much for your time today. Would you like to provide any closing remarks for our audience before we go?
Sure. Well, first of all, I want to thank everyone for taking the time to listen, but also, I think just stick with it. I've been here since, dealing with COVID since February 26th and probably a couple weeks even before that of 2020. But the reality is you got to stay with it because the science continues to evolve and we have to remain flexible and open-minded in terms of what we do to continue to fight the pandemic.
Absolutely, and thank you again, Dr. Tran, for your presentation and for your important research. And I also want to thank LabRoots and our sponsor, Dia Soren, for underwriting today's educational webcast. And before we go, I want to thank our audience for joining us today and for their interesting questions. Questions we did not have time for today, and those submitted during the on-demand period will be addressed by our speaker via the contact information that you provided at the time of registration. And this webcast can be viewed on demand. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, stay healthy and stay safe. Take care, everyone. Bye-bye.